This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by.
Welcome to today's meeting of the Health Committee. Members of the public may like to follow at London Assembly on social media and use the hashtag AssemblyHealth for this meeting. The main item on the agenda today is HIV in London. However, we have a few short items of business first. At the plenary meeting on the 23rd of January, the Assembly agreed changes to committee memberships. And Assembly Member Desai has joined the Health Committee, and our thanks to Assembly Member Marina Ahmed, who has stepped down. Can I now ask the Clerk, Diane Richards, to confirm any apologies for today's meeting?
Thank you, Chair. Apologies for absence have been received today from Assembly Member Desai, and also in accordance with Standing Order 2.4D and with permission from the Chair, Assembly Member Wilson will participate in the meeting virtually today.
Thank you. Can we note the list of offices held by Assembly members, and can I also ask members if they have any disclosable pecuniary interest in any specific items listed on today's agenda? No. Can we confirm the minutes of the meeting held on the 18th of November 2024? And can we note the completed and outstanding actions arising from previous meetings and additional correspondence received? And can we note the action taken by me under delegated authority in consultation with party group lead members to agree the dentistry and oral health in London report? Thank you. And that brings us to today's main item. I'd like to extend a warm welcome to our first panel of guests joining us to discuss HIV in London. We have with us Professor Kevin Fenton, CBE, who's the Regional Director of Office for Health Improvement and Disparities in London, OHID. It's not easy to say OHID than the whole title. Regional Director of Public Health for NHS London and the Statutory Health Advisor to the Mayor of London, GLA and the London Assembly. We have Adrian Kelly, who is the Lead Commissioner for London Sexual Health Programme, and Mark Thompson, who is Lead Commissioner for the London HIV Prevention Programme. I welcome you all to today's committee. The first question will be from myself, and it will be for Professor Kevin Fenton. What are the key challenges in reaching zero HIV targets in London?
Thank you very much, Chair, and good morning, colleagues. The last 4 decades have been remarkable in terms of the journey that we've had in diagnosing, treating, managing and supporting people living with HIV. And we're now at a phase where we can speak about the decline of HIV incidence, both here in the United Kingdom and around the world. And we can even be bolder in setting bold targets to work towards ending HIV transmission by 2030 in the UK. The journey to ending HIV transmission, however, will be challenging for a number of reasons. As incidence declines, it means that it's going to become harder to identify people who may be living with HIV or acquiring HIV infections. As new infections decline, we can expect to see the people who do become and who do acquire HIV are more likely to have complex lives. They may be having higher levels of risk behaviors. They may be poorly engaged with existing treatment and care services. They may be dealing with many of the social and structural drivers of transmission, including poverty, insecure immigration status, and other key structural factors. So as we progress towards 2030, the ambition to end HIV transmission is the right one, but it means that what got us to this point will not be sufficient to get us to 2030. It will require strengthening and scaling our HIV testing efforts, really expanding our work on HIV PrEP access and utilization, because we know PrEP is so powerful in preventing acquisition of HIV, and more people need to benefit from PrEP, including young gay men from Black and minority ethnic backgrounds, and heterosexual populations. It also means we have to do a far better job of managing people living with HIV and ensuring that they're retained in care as a core part of using the powerful effect of treatment on preventing onward transmission. And finally, as we get towards 2030, supporting people living with HIV, both in tackling stigma and ensuring that as people age with HIV, they're able to benefit from holistic care for chronic long-term conditions will be a key part of people living healthier, longer with HIV. So in a nutshell, those are the 4 key challenges, but also opportunities for us as we progress towards 2030.
And just looking at particular communities, for example, Black African communities, what are the reasons for the recent rises in cases amongst this community in particular, and what can be done to address this?
So one of the things we know about the epidemiology of HIV, especially as we progress towards the ending of the epidemic, is that as incidence declines, your trajectory of new infections becomes somewhat what we call in epidemiology more volatile. Because your numbers are smaller, changes in population movement, new risk groups who may be at higher risk of acquiring HIV. If those populations change, you can see fluctuations in new diagnoses of HIV occurring. And over the past couple of years, that's exactly what we've seen. While we have maintained the relatively strong declines of new HIV diagnoses among gay men in London, we are seeing new patterns emerging, of which the most recent increase in infections acquired through heterosexual intercourse, especially in Black people from high prevalence countries in sub-Saharan Africa, has been a key feature. We believe that this rise in new diagnosis has been a result of in-migration to the UK, but we're also comforted that most of those who've been diagnosed in the past year have evidence of being on effective treatment and have been virally suppressed, suggesting that people in migrating to the UK are diagnosed, already in care, and therefore at low risk of transmitting infection to others, and are getting access to effective treatment services. But, Chair, it's important that we don't focus solely on that population, because as we get to 2030, new populations are emerging. So, for example, I am concerned about HIV new infections among young gay men, especially young gay men from Black and minority ethnic backgrounds. We have to keep a very close eye on HIV in inclusion health populations, because when infections are transmitted among people who have poor access to services, there's a real risk that it can escalate. So new populations, existing populations, and emerging populations we have to look at in the round.
Just thinking about health issues in general. So in some cases, professionals want to see, or the NHS wants to see, the numbers going up because of the numbers of people who may have been diagnosed, and actually seeing numbers going up could be seen as a sign of success in the sense that at least now we're aware that people have HIV, for example, and can then go on to a course to manage and deal with it. What would you say is the kind of your take on what we're seeing in the numbers right now?
Yes, it's a challenge in epidemiology and in public health where you want to see these increasing numbers, and the increasing numbers is suggesting that our surveillance systems are working, that our testing systems are working, and we're able to link people into care. And that gives us both the resilience to understand how our systems are being supported, but it also means that if there's any changes, that we're able to pick them up early and therefore respond. In the last 3 years, we have significantly increased our HIV testing capacity nationally as a result of the opt-out HIV testing program in emergency departments and further scaling up of HIV testing in communities funded by local authorities through the public health grant. So the magnitude of increase in testing is providing us with the safety that people who are coming in or moving around the country are able to diagnose them much more effectively. And we know opt-out testing has been particularly good in identifying heterosexual populations, those who've in-migrated to the UK, but also people who've fallen out of care as well. So the fact that the numbers are increasing are a sign that actually we're on top of our testing, diagnosis, linkage to care, but it is also giving us the early indications of changing epidemiology so we can make mid-course corrections if necessary.
Okay. And you mentioned the public health grant. What are the main challenges faced by HIV services commissioned by local authorities? And we know about sort of obviously the cuts in public health grants over the last decade or so. What impact has this had on these services?
So as you know, this is an area of great concern to us in public health. If there is a net reduction going into the public health grant or a net reduction in the purchasing power of the public health grant, it means that there's a real risk that critical public health services can be reduced, or we drive greater efficiencies and productivity through the existing resources that we have. And the picture currently is a mixed one. The fantastic work of our colleagues in HIV and GUM and family planning services and reproductive services means that there's a lot more innovation, new models of care, introduction of digital approaches, thinking about workforce and skills mix in order to manage this. But at the same time, we know that the needs in the population are increasing. STIs are increasing. We have the big challenges of HIV. So there's a real danger that we may fall behind, even with the innovation and greater productivity, of not being able to fund control efforts at scale. And so I think this is a challenge that we have now, given the economic circumstances that we're in, of driving greater productivity, focusing and prioritizing our action, and of course using data to be able to focus our efforts and evaluate the impact of our efforts as well.
Okay. And in terms of the Mayor of London and the GLA, what is the Mayor and the GLA doing to support the work to reach zero HIV targets, and what are the key actions that they've taken to date?
So the Mayor plays a very critical role as a powerful voice for London and for Londoners. And while he doesn't have direct commissioning responsibilities or delivery responsibilities for HIV or sexual health services in London, he and the GLA play an important role in 3 key domains. First, being an advocate for HIV and sexual health issues. The Mayor, as you know, has been has been the lead for the Mayor's HIV Fast Track Cities programme for London, an innovative programme that drives multi-sectoral collaboration in the city to focus on reducing HIV and tackling stigma. And the Mayor has been a strong supporter of this programme since its launch in January 2018. That advocacy is powerful. It links us to cities globally, and it also links us to cities across the UK to share best and promising practices on what we're doing. So advocacy is critical. Second, because the GLA is covering a range of other areas of import to Londoners, including inclusion health populations. The Mayor also has a strong role to play to integrate and to promote collaboration between various programs. A good example of this is the Mayor's work on violence against women and girls and ensuring that links are made between VOG programs and sexual assault programs and sexual health screening and services. Similarly, the Mayor's advocacy and work on homeless populations, who we know are an important inclusion health population, is going to be critical to ensure for Hep C, Hep B, HIV testing services, we look for those links. Finally, there's a third element of the work of the Mayor which is really critical, which is working with system leaders such as myself and those seated here, that when we identify threats, challenges or emerging issues affecting Londoners, for him to be able to advocate with national government or with local government to say, this is an issue and we need your help. Great examples of this are the Mpox epidemic. You remember we had the introduction of the Mpox 2 years ago. We've seen subsequent waves of the Mpox epidemic, and the Mayor's voice was important both in advocating for an early response, adequate vaccine supplies for the city, and with a new, more serious clade of Mpox that has been identified, the Mayor has written to national government to ensure and to assure London has the support it needs as well. So advocacy, creating connections between programs, and then ensuring that there's a voice for what London needs is, I think, a critical role for the Mayor.
Okay, thank you. I'm going to move on to Assembly Member Best. Oh, sorry, Andrew. Yeah, Assembly Member Boff would like to come in.
Thank you. Professor Fenton, you outline what the Mayor is doing to support that work. Do you think there is a space for the Mayor to do a little bit more with the public estate on TfL to promote public health messages? Because I don't see any on the underground related to either HLV or indeed sexual health.
You know, one of the things we know is that the way people receive and obtain their information is changing rapidly. And in fact, whether you're taking the tube or not, most people are on their phones, on social media, and consuming information in that way. Given the financial circumstances that we're in currently, we work with our colleagues to identify we're finding the best channels for the communities at greatest risk. So we're far more surgical in targeting our campaigns. And I'm sure Mark will speak about the work that they're doing in Do It London. Where there are opportunities for us to work with the TfL estate, we will certainly raise that with the Mayor, because that's a great opportunity. But is it the most effective opportunity? We'll see. We have to base that on our data, on our research, the market research that we do. Because to be honest, especially for young people and how young people who are our target audience consume information today, there are far more efficient ways for us to engage them and to use those resources effectively. Yeah. Thanks.
Thank you. Assembly Member Best.
Thanks. And Kevin, I would warn that was a scary advert to put people we rely on to invest in TfL adverts off doing that. It's certainly there is a lot of good in advertising on the TfL estate, which is why people still pay hefty sums to get their adverts across the TfL estate. And let's not tell them that it's not good, there's better ways to do it. The Mayor obviously has his own adverts. He already has access. He already has, you know, that stream of adverts that wouldn't affect revenue. So I do think perhaps all avenues are good, so it's good to look at social media, but we know the boroughs that we want to target, so would it not be good to focus on using the TfL estate in those boroughs? We know we have the means to do it because we already have the space where we're not taking revenue, and we know where we need to target.
So I agree that if marketing didn't work, it wouldn't be done on the tube. I think my point is, are we using the right tools to reach the right people? And how do we use and make those decisions based on the best evidence? It may well be that actually using some of that estate on TfL might be better for other campaigns, mental health, for example, heart health, others. So we'll see what the data tells us. And that's what we do in terms of evidence-based programming for health marketing campaigns. So thanks.
Thanks. If we could see it being used for anything, I think that would be a step in the right direction. Mark, come to you, and welcome to the committee. How does the London HIV prevention programme work? And do you want to talk a little bit about kind of the impacts to date?
Yes, sure. Thank you very much, and it's a real pleasure to be here today. So just a bit of background. The London HIV Prevention Programme is a citywide initiative that aims to reduce new HIV diagnosis across the capital. Through the programme, we promote HIV testing and the other prevention methods through campaigns that Kevin has just mentioned, such as Do It London, but also specifically through outreach and engagement to key populations. The programme was established in 2013 by London Council leaders and has been renewed multiple times since then, most recently in 2024, taking us up the current contract to 2027. The programme is commissioned by the London Association of Directors of Public Health and sits within the shared programmes portfolio. So there's great opportunities for us to work with colleagues who are working on community-based initiatives, other health issues, so we can create great links there. And the governance of the programme is overseen by a leadership board, which is led by the Director of Public Health at the ADPH, and representatives from the 5 ICB sub-regions, UXA and London councils. And the programme is managed by Lambeth Council and is funded by all 32 boroughs. The contributions that the boroughs make are based on prevalence in their local areas. But as already been alluded to, because of the ongoing issues around what local boroughs are facing, around their financial constraints and the public health grant, we are thinking about what the programme may look like in 2027 and beyond, and how we might need to streamline that, and how to make sure we're effective and reaching the communities most at risk. So as I've said already, the programme focuses on signposting the 4 key proven methods of HIV prevention. And I'll first of all start with the out-of-home advertising, because that's where we've just left off from. And we do the Do It London campaign across all London, and we've been doing that for several years and through social media channels. And the campaign directs Londoners to HIV testing in clinics, community settings, and to Sexual Health London. The visibility of high-profile campaigns such as Do It London presents up-to-date information and normalises HIV, which also has the additional outcome of keeping HIV in the public sphere, and therefore can play a role in reducing HIV stigma. But again, as Kevin has already said, there is a real opportunity for us as we go forward to look at how we reach diverse audiences, how we segment, and how we target that. In terms of the impact of the programme, I think I'll lean into the work that we've done specifically with GBMSM over the past few years. As you know, new HIV diagnoses have dropped significantly in the past decade in gay, bisexual and other men who have sex with men, although we are seeing some pockets of those communities where that hasn't happened as fast. We're thinking about migrant men and young black men and young gay men generally. Through the programme, over the past 4 years, we've delivered over 60,000 GBMSM have been engaged in outreach. Over 50,000 have been engaged online. We currently work with over 60 venues which GBMSM frequent across London. And this year we developed a pilot with Sexual Health London to go out into communities and engage men to get them to start taking up the sexual health kits, therefore reducing burdens on clinics and therefore engaging men in new technologies. And last year, over a 3-month period, over 400 kits were distributed to men. So we see this as a new opportunity for GBMSM to take forward that work, to take forward that tool of prevention. We recognise that the programme previously hasn't worked and didn't have an arm for black heritage communities, and I'm really excited to tell members today that from this year we have started to pull a new arm into the programme which will work specifically with black heritage communities, and we're currently conducting a needs assessment into the HIV prevention needs of black heritage communities across London, which will then inform a new service to begin in the summer of this year.
Thanks. And you answered a lot of my questions, but I do have some follow-ups. You talked then about a lot of the programmes focused at men. Obviously, especially women, especially black African women, are a target group.
Yeah.
What specific programmes have you looked at or are you implementing at the moment?
So, I mean, you're absolutely right. So the programme, as I've said, did traditionally have those two arms of working with GBMSM, because that's where the epidemiology led us, and also the mass media, the whole kind of communication was targeted to all Londoners. With the new Black Heritage programme, which we are about to commission, we will definitely ensure that there is a real strong arm that goes through that to work with black women. Through the needs assessment we're currently conducting, there has been a significant number of black women who have engaged in that needs assessment. We're about to conduct some focus groups because we want the programme to be evidence-based, and we also want it to respond specifically to London residents' needs. We don't want to make something which is top-up. We're also working very, very closely with black-led and black African organisations who already have a footprint doing that work to ensure that we're meeting the needs of their community. So women going forward will be a central arm of the London HIV prevention programme.
As an outsider, my observation is where we've kind of shifted the dial that this isn't something that only gay men or men who have sex with men need to think about. It's still something that women, especially married women in their middle ages or older, don't think is anything to do with them. Is that something that you would still observe is the biggest kind of gap in how people observe that their needs in relation to getting tested?
Yes, absolutely. I think, as we said, over the past couple of years, we've seen a rise in heterosexual diagnosis, and particularly with people who are of an older age group as well. And one of the things we're looking forward to, because we're revamping and we're revising the campaign, the Do It London campaign, and that will come out in the summer next year. We're actually taking a new approach, which is to move away from just the individual, because what some of the research is telling us right now is that many people are disengaging with the work that we're doing because they do not see HIV as an issue for them. They recognise it, if we think about black African women, recognise HIV as being part of their community, but not something that they as individuals may be at risk of. But we also have to marry not stigmatising particular communities, because then they completely switch off. So we're looking at work that's been done by prostate cancer around black men, work that's been done around blood donation, which leans into community, which leans into doing something good for the people that are around you. And I think if we take that route, that is one avenue for us to take, but also recognising that HIV doesn't stand alone. It doesn't act in a silo, and we have to make sure we're making links with, as Kevin has said, all opportunities around violence against women and girls, sexual and reproductive health. These are all of the areas that we need to be leaning into for HIV prevention work to truly meet the needs of women in our city.
Thanks. With so many national and regional and sometimes local programmes, how do you make sense? How do you measure what you do that has made that? You talked earlier about the impact, but how do you measure what it is that you're doing which is successful compared to perhaps maybe things that haven't worked as well in the space of so many other programmes running? How do you attribute the successes of your programmes? How do you measure those?
I think that we can measure that from, if we look again at the GBMSM work that's been done, that work has been really rooted in community. And community organisations have worked really well alongside the system. They've evolved their practice. They are reaching gay and bisexual men across the capital, which has been evidenced by the uptake of PrEP, by the reduction in new diagnosis. We've seen an absolute sea change in men's engagement in HIV testing and understanding that this is something which is part of their lives, which is normalised. So I think when we see that shift in not just the numbers going down, but a cultural shift as well in gay men in the capital, that is a real marker of evidence of success.
Thanks. And to what extent, obviously, the Pan-London work, you talked earlier, sorry, about it being their Pan-London work. To what extent does that avoid a postcode lottery in London? Or perhaps is there some areas where you're going to receive a better service or more outreach services?
So
and there might be good reason as well. Sorry, I should say that.
I mean, absolutely. I think what's quite interesting about the new programme going forward from the April of this year is that with the Black Heritage work, we can really look at how we target that and look at some of the outer boroughs where we know there are larger populations of people from Black Heritage living in those boroughs. The work for GBMSM has focused very much in central London, but we've actually over the past the past year have worked with our providers to try to make sure that those aren't just in those spaces, because we know younger gay men are socialising in very different ways in very different spaces. So we're constantly keeping an eye, reviewing the venues that we've worked in, etc. And I think with the Black Heritage work, it is going to be a case of pinpointing and targeting, but working really closely with local communities in those areas to make sure that we're working with their populations there, and also working really closely with our commissioners across London to make sure that they're involved in the programme and that the communities that they're funding and supporting have opportunities to engage as well.
Thanks. Obviously, you mentioned earlier starting the work in 2013, and we've also talked about the technological advances and social media since then. So how have you evolved in the programme since 2013, and how are you making sure that you're ready for the future in terms of using technology for good?
So over the years, I mean, we started out being very, very print-based, very out-of-home advertising, bus shelters, big posters all over the tube, and obviously at the time there was a huge gay press then. We've really shifted over the years. We've done a huge amount of social media content. We're very, very proactive on our social media. We've done big campaigns on social media, and we're looking at different ways of developing that. Going forward, in part of the brand refresh, we'll have a brand new website, which currently is only in English. So we'll be putting that in multiple languages across the site for the populations of London. Our digital advertising that we do, again, is very, very targeted, as well as our organic stuff that we do. And again, trying to make that multilingual as far as we can. Looking at how we use influencers and community voices to amplify our messages and to champion what we're doing. That seems to work really, really well. And actually, we're starting to explore how we might use AI, how we might use chatbots on our website and our digital platforms so people can access information, can access and be signposted to services such as SHL London really, really quickly. And that will also help us to evaluate, measure the impact and the outcomes of our programme.
Thanks. And finally, Mark, from me, anyway, what more could the Mayor do to support the Do It London campaign? You talked a lot earlier about the Do It London campaign, but as well, if you wanted to add anything else that you think needs to be said about it.
Yeah, I mean, I think so far the Mayor has been a great supporter of the campaign, you know, either through amplifying it through key points like Testing Week, World AIDS Day, and I think it's constantly about keeping the foot on the gas and reminding Londoners that this work does exist. I think as we roll out the brand refresh and the new campaign, it becomes more targeted, and again, I think you'll all be quite excited that it is speaking to Londoners as opposed to just individuals, and we're all in this together. To have the Mayor and the Mayor's office behind that would be brilliant, and taken on board the conversation about TfL, I think there are opportunities to see how we can do that really smartly in the future, because I think there could be good opportunities to look at how we can use that to not just promote the four ways, but also the Mayor's voice is great at reducing and addressing HIV stigma in the capital.
And just to be clear about that, when you say supporting, is that resharing the messages you have? Is that engagement? Meetings, or is meetings with Kevin enough? Is that what
I think those are good. I think those are good starting points. Is to engage with colleagues like myself and Kevin, but it is also to ensure that the Mayor's office is behind our campaigns. I saw recently the Mayor's officers signed up to the HIV Confident Charter, which is great work, and that's been publicised and promoted, and I think that says to Londoners and to all our key stakeholders, the Mayor and his office are invested in this work, and if we can have that support going forward, and even if this is somebody as simply reposting and sharing content, the audience and the capture is huge, and I think that says something quite important.
Thank you. It's sort of taken me down a trip down memory lane because I was at the launch in 2013 of the Do It London campaign. 11 years ago. It's frightening, but I was, at the time I was cabinet member for one of the boroughs that did contribute to the campaign. But I'm glad to see how it's evolved, because I do remember the focus of, being very much on print and, even in magazines and publications where people were likely to see or consume someone's information, but that move into the digital space, I think even as politicians we'd agreed we've changed how we campaign, for example, and reach the public. So I'm glad to see that evolve in public health messaging as well. That's me going off script, but I've got a question from me really around welcoming the focus on and the increased resources on focusing on people with black heritage. When will you be in a position to tell us in more detail what that will entail?
Absolutely. So, as I said, we are now midway through conducting the needs assessment, which is being commissioned by the London HIV Prevention Programme. Over the past few months, we've done a deep dive into what the desktop evidence is telling us around the needs of black heritage communities. All London commissioners have been surveyed, sexual health and HIV commissioners, and we're currently conducting a resident survey to all black Londoners, and we've promoted that quite widely. We have about 400 respondents at the moment, and that will run for a couple more weeks. Our aim is to have the final report ready to be published at the end of March, and we'll be socialising that quite broadly to key partners and stakeholders. And then my team and I are now starting to work on what the service will look like based on the interim findings, and our aim is to have that out for procurement in the early summer, with a launch as soon as we've got that through the door.
Thank you. In that case, I'll move on to Assembly Member Voss.
I think we're going to be very interested to hear what that campaign looks like, because from my naive reading of the data, the rise in HIV infections is not the black community, it's specifically black Africans, isn't it? Is that correct?
Yes.
Yes. So be interested to see how you're going to target those messages to that group. We're really fascinated to hear that. Mr. Kelly, how does the London Sexual Health Programme work to deliver open access sexual health services in relation to HIV, and what are the key challenges faced by that programme?
Thank you. So the London Sexual Health Programme is 31 authorities who come together to coordinate the commissioning of open access sexual health services. It's an unusual part of the NHS in that people can go to services outside of their area, and that has been really important because of the stigma around STIs generally and HIV specifically. People need options to access testing in different locations. We work with the authorities so that the commissioning of those services from the NHS is coordinated, coherent, and as consistent as it can be. The open access sexual health services in relation to HIV specifically provide HIV testing and the seamless transfer of care to HIV treatment services for people who are diagnosed, so that they can be initiated onto treatment and achieve viral suppression. The open access sexual health clinics also provide pre-exposure prophylaxis, PrEP, which helps HIV negative individuals to continue being HIV negative. Also post-exposure prophylaxis, which is similar to PrEP, but it's episodic, and it is taken immediately after an exposure element. That's one arm of what the programme does, is around the open access services, and the other arm is around the digital and the online service, which is provided in 30 of the 33 authorities of London. But I think on the first question, you were particularly concerned with the clinics.
clinics, but the next question is about digital. So,
with the online sexual health service, because the change in the Health and Social Care Act and the transfer of responsibility for commissioning sexual health services, the only bit of that NHS reform from Andrew Lansley, massive reform, the only bit of it that required legislation was transfer of public health commissioning responsibility, including sexual health. So it was a big fundamental change in the way that services are organised and the accountability loops, putting the local authorities of London in far greater control of what's delivered to their residents and having a stronger kind of role in terms of oversight of delivery. So sexual health testing has just gone up and up and up year on year throughout my lifetime, and then in 2016 that increase in London stopped and it flatlined for 2 years, and that was because the money had gone. There was no money left to continue paying under that clinic service delivery model alone, and so the authorities of London decided they would commission an online sexual health service so that the increasing demand for sexual health testing could be met within the resources that were available. Online digital sexual health testing and self-sampling is obviously at a cost far less than in a clinic, but it's not suitable for every person. It's particularly good for people who are asymptomatic, don't have symptoms, and just need a routine checkup. And of course, in the time since SHL was launched in 2018, we have onboarded routine commissioning of PrEP, so that asymptomatic testing for individuals who are using PrEP. It's even more important that we were able to meet that demand within the finite resources that we've got. The online service is people go online, they register for an account, they complete an initial consultation which determines what STI tests will be offered and the things that go in the kit for taking their samples, because obviously we take different samples based on sex. So although in addition there are questions about PrEP eligibility, and while we can't currently provide PrEP online or remotely, we do signpost people to static information on our website which tells them where they can access information or access PrEP directly from in clinics. So when they've done the consultation, a kit is sent to their home address, or they can collect one from a clinic or from some outreach services. They take their own samples, which will be a sample for testing chlamydia and gonorrhea, and then a blood sample for testing HIV, syphilis, and depending on their circumstances, hepatitis B and C. So they return their samples, they go to a laboratory up in Sheffield, where it's a dedicated STI testing laboratory, state-of-the-art modern facility, and it's very slick. Things work really quickly. If somebody's got negative results, they'll usually get their results as early as the next day, often. And the results, if they've got reactive results for bloodborne virus like HIV, they get a message to say that the health advisors need to talk to them, and the communication of a reactive bloodborne virus test result is delivered over the telephone by a real person. If it's just something like simple chlamydia, they'll log into their system and they'll be able to see that they've got a positive result for chlamydia, and they will then be offered the opportunity for remote treatment. Where they've got positive results for bloodborne viruses, they will receive not just telephonic support around communication of the results, but also support with going into a clinic where they can get confirmatory testing, particularly for HIV. The tests that we use are fourth-generation HIV tests, extremely sensitive, and so a lot of the reactives, most of the reactives will be false. So they won't be an HIV infection at all when they do confirmatory testing in the clinic. For those individuals, we can resend a blood kit and they can retest with us. But if a person's circumstances mean there's a good probability that they may have an HIV infection, they will receive repeated telephonic support until we have assured ourselves that they have attended a clinic and confirmed that result in either direction. And when we first started, one of the early diagnoses we made around HIV was a weak reactive, and a weak reactive would normally not be HIV. This was in a gay man, though, so obviously the clinicians communicated the importance of them attending the clinic. They were booked into a clinic that very same day, and the HIV was confirmed and the viral load testing was done. So the tests are so sensitive. This was 2 weeks after their exposure. When I started, it was you had to wait 12 weeks after exposure for a test, and then it would be a month before you got your results. So 4 months between exposure to diagnosis. This guy, it was just 2 weeks after their exposure. And when they went into the clinic to attend for their diagnosis, and this was one of the major hubs that diagnoses most HIV in London, they had not seen a viral load as high as that person in many, many years. The viral load is very high. In terms of their journey, they hadn't seroconverted. They had no seroconversion symptoms. They wouldn't know they were HIV positive in any way, shape or form, but they would be highly infectious. So that's an example of in terms of the SHL speed and ease of access of testing and the sensitivity of the tests that we provide through the service have enabled us to support the prevention of HIV transmission in undiagnosed people.
You emphasise there, I mean, it seems to be a bit of a mixed economy. So online, extremely important, innovative, can be quite focused. But those other sexual health clinics are important as well, where people can actually turn up. And so I'm quite pleased that we have now seen the threat of closure to the sexual health clinic in Enfield removed after a great campaign by Councillor Ruby Sampson up there, who brought it to the fore. So those services are important because a lot of people don't really understand online. Is that correct? And
you know, one of the leading clinicians in London always at meetings reminds us to check our privilege in London. So while we do want services to be as close and accessible to us, you know, in other parts of the country you might need to travel for 2-3 hours to get to your nearest sexual health clinic, and in London within 2-3 hours of public transport you've probably got 50, 60 clinics you could attend. So, but obviously for reaching more vulnerable communities, which, as Kevin has said, is the key part of the future for getting to zero on HIV transmission, we do need to make sure that services are available where people are at. And, you know, we could survive without an online testing service. We can't survive without clinics. That, you know, that is a really key kind of thing to stress to people. You know, the SHL is an add-on. It complements. It helps us cope with the demand in terms of the finance. It's not a replacement for clinical services. But in terms of barriers to, and digital isn't for everyone. There are barriers to digital for some people, but there are barriers to clinics as well for a lot of people. And digital sexual health means that everyone, nearly everyone in London can get the sexual health clinic to be delivered through their letterbox. And I think that is an incredible change in terms of delivery. PrEP and effective HIV treatment has been the most incredible thing that's happened in my lifetime and career in terms of HIV outcomes, but in terms of service delivery, the most radical change I have witnessed has been the introduction of online services to complement the provision that is in the clinics.
And the risk of I always check my privilege whenever I get annoyed having to wait 7 minutes for a tube train, and I do get very annoyed, and then I think I could be living in Newcastle, Nothing against Newcastle. There are other cities. I've asked this question of Professor Fenton before, and it's not because it's Professor Fenton, but I've never received a reply that I really understood. Why can't I just walk into Boots and buy some PrEP? Rather than having to see a GP. If you're going to go on to PrEP, that obstacle, I'm going to have to see a GP, that gets in the way. When is the time I'm going to be able to just walk into Boots, buy a packet of PrEP, and go have it? Whoever wants to answer.
I agree with you. And as part of the National HIV Action Plan, which I have the privilege of chairing, I'm the government's chief advisor on HIV as well, expanding PrEP access through community pharmacies and the huge pharmacy network which we have is a #1 priority, because we need to lower the barriers of access to PrEP, and we need to ensure that PrEP gets into much more diverse communities. However, my understanding is that there still remains regulatory challenges and funding challenges to do this, so that when you walk into the pharmacy to get your PrEP, it will be at a low cost. So there's a difference between going in and purchasing it at cost versus can we get it in at the NHS price so it's free or low cost to everyone. So this is a priority for us, and we have a number of pilot studies which are happening across the country now, and partnerships with different pharmacies to explore how best to do this with the NHS, so we can both have scale of distribution and the price point or free of access for people who need it. That's the challenge that we have.
I mean, that's how gay men got PrEP in the first place, was buying it themselves. The thing that wasn't happening there was the renal monitoring that currently is required, although new guidelines are out for consultation that may ease that, but there will always need to be, for some people, monitoring of kidney function, which requires a test. Currently, those tests are only shown to, or recommend, the only tests that are recommended in the guidelines around them have to be delivered in a clinic. There is a pilot in one part of the country that is looking at remote renal, because of the novelty of it, there is risk, which is why it's a relatively small kind of scale pilot compared to just letting it loose on a city the size of London, which would be a very different proposition. So we're waiting to see the evidence to come through that the remote renal monitoring is good, is safe, can be shown to provide an equivalent level of clinical quality as the attendance in the clinic. And at that point, we'll be in a position to confidently commission remote PrEP at scale, but when we're very close to that, but we need a little bit more evidence to do that.
Thank you very much, and I will continue to ask that question until the reply is yes, you can. But thank you, Jim.
Thank you. Going to turn to Assembly Member Wilson, who's online.
Thank you, Chair. So my first question is kind of picking up something, Professor Fenton, you mentioned in your introduction, which is about stigma. You mentioned that as being one of the challenges. So I'd just like to explore that a little bit further and to understand to what extent that is still significant in trying to reduce rates of HIV, what action can be taken to reduce the stigma, but particularly whether that is an issue in some of the other the groups where we haven't seen the prevalence come down. Talked a bit about sort of Black African, but also kind of heterosexual males perhaps feel that this is a gay issue when it's an issue for everyone. How can we challenge that and improve uptake of things like PrEP in those other groups?
Thank you very much for raising this incredibly important part of our journey to end HIV transmission by 2030. Some of you would have heard me say on World AIDS Day events or other events on HIV that HIV stigma kills. It prevents people who are diagnosed or at risk of HIV from getting HIV tested. It prevents people who've been diagnosed from remaining in care. It prevents people who are diagnosed and living with HIV of sharing their diagnosis with those who they love and are able to get the sort of mental health and social support that can allow them to thrive. It prevents them from engaging in the workforce and being able to support themselves to have long and fulfilling and healthy lives and economically secure lives. And as we approach 2030, tackling stigma in all its forms will be critical. We talk about the internalized stigma that people living with HIV experience, the shame, the guilt, and how that prevents them from accessing services. And we tackle that by education, by peer networks, by peer support, supportive clinical services, and helping to link people into those wider social support services that they need. But we know that many people living with HIV grapple with external stigma. Unfortunately, most of it comes from the health and care service, from the GP practices, from the receptionist, from going into the hospital, accident emergency department, and having to declare your HIV status, and to watch as people pull back, double glove, put on a mask, ask you how you got HIV infected. So for the external stigma, we know that that's a function of poor understanding of HIV. And as you rightly say, Assembly Member, as we approach the ending of HIV transmission, fewer and fewer of us are going to know someone who's living with HIV. And so stigma is likely to become, and lack of awareness and ignorance on HIV is likely to become worse. Similarly, we know that only 20% of Londoners know that if a person is on effective HIV treatment, that they are unable to pass HIV on to others. So there's also a risk in the population that people don't know about the good news on HIV today to help to address stigma as well. So what can we do? There are a few things that we're doing in London which I think are really exciting and are really setting the pace nationally. You've heard already about the HIV Confident Charter, which is working with employers, businesses, and a variety of settings, including the healthcare system, to raise awareness about HIV, ensure people are trained on HIV, and helping to address stigma and tackle stigma. We have our HIV ambassadors, which are also funded and supported by London Fast Track Cities programme with Terence Higgins Trust, and that's an opportunity for us to really ensure that people living with HIV become advocates on education, raising awareness, engaging people in schools and businesses about the face of HIV. But most importantly, the work that Mark and colleagues have described of continuing campaigns, continuing to raise awareness about HIV, that political leaders play on saying that HIV is still an issue and stigma is still an issue remains important as well. So, remember, a bit of a long response there, but this is such an important topic, and we will not get to zero by 2030 if we fail to address stigma. But the good news is we have the data and we have the evidence on what to do, and we're committed to doing this in London. Thank you.
That's great. Thank you very much. So it sounds it's still quite a bit of work to do on education and awareness, but it's very much part of the agenda, and hopefully will continue to be so. So my final question then is a kind of more kind of all-encompassing question, I guess, to anybody that wants to sort of jump in, and whether it's by repeating some of the key things we've already talked about, or whether it's anything new that hasn't been covered yet in the discussion. So what kind of further action or steps or measures, programmes would you like to see take place in London so we can help reach the 2030 zero target? So open to anybody, please.
Thank you very much, Assembly Member. I think obviously the ongoing support and amplification of the work of Do It London, and also the outreach and engagement services that we're going to be delivering over the next couple of years are absolutely essential. And I think what Kevin has said earlier, I mean, we're not going to get to zero unless we truly do address HIV stigma as a central part of what we do. And this is when we need politicians, we need local councillors, we need the health Health Service to absolutely get behind this and challenge this in all of its forms. We know that it's pernicious, and we know that it has an impact on individuals, but it also impacts a wider society. So I would say we can't afford to take our foot off the gas, even as we continue to have the successes that we have had, and we should celebrate those. We have great opportunities in the capital to lean into and make a huge difference. And I think that's also about how we join up our services, how we're making sure that HIV no longer sits in a silo on its own. We know that our communities and key populations don't live in bubbles. We don't live in isolation. We all interact. We're all part of this great city. So the only way we're going to tackle this is a whole systems approach, is a whole communities approach.
An Assembly member, I'll also add to Mark's excellent response. I think there are three things that we need to be laser focused on to get us through the next 5 years successfully. The first is having that vision and strategy for getting there, and I'm really pleased that the government has committed to rewriting and updating the current HIV action plan. And as part of our work on that plan, we're really not only thinking of scaling up what we know works, HIV testing, access to PrEP, keeping people in care and tackling stigma, but the new action plan is going to be focused on system strengthening and better governance for the delivery and accountability for the delivery of the plan. In other words, Assembly member, ensuring that every part of our fragmented health and care system understands what the mission is and understands their unique role in getting to zero. And this means engaging primary care. It means engaging ICBs. It means engaging accident and emergency departments on getting the job done and working with local government, working with regions, and working with national. The second thing, Assembly member, is that we need to be prepared for new threats and emerging challenges toward journey towards zero. As Assemblymember Boff had said, over the last 2 years, we've seen how quickly the epidemiology can change, and that means as we go to 2030, we need to be agile, look at the data, respond to the data quickly so that we can respond to emerging threats and challenges. And I think London, through the Fast Track Cities or work with our partners at this table, is well poised to be agile because we're looking at the data from UK HSA and we're checking to make sure we're having the right interventions and we're doing the right things. And then finally, the third ask to get to zero is that our community infrastructure and architecture, which has been essential in getting us to this point, voluntary sector organizations, that we work our hardest to maintain and strengthen our voluntary sector infrastructure. We cannot get to zero without our communities and without our community infrastructure. And I think working together with the health and care system and others to ensure we have that social safety net will be key. Thanks.
I think I would just like to really add and take a particular look at the issue about resources, and I'm grateful to you for raising the issue of Enfield. I think that indicates to us about the pressure on resources within London around sexual health. And I said that STI testing had flatlined 2016-17, and with SHL it had started to increase. The increase in the number of tests provided to Londoners between 2018 and 2023, the increase was 46%. We did half as much testing again as we did in 2017 in London. If you compare that with the rest of England, the increase was only 21%. So the increase in testing we have delivered in our system with flat funding, you know, has been incredible. We can't sustain that level of efficiency driving forever, and we absolutely must have the clinics. And when push comes to shove, it is the clinics that need to be preserved above all else. And I looked at your notes from the previous meeting, and the excellent slides, always excellent slides from UK HSA. The one that stood out for me, the chart in there, was the volume of STI testing delivered to gay men in London and in the rest of England. And in the most recent year, it virtually level. London provides as much STI testing to gay men as the rest of the country does wrapped up together. We do not receive in London the level of public health funding that the rest of England receives rolled up. Yet we are having to do our system has to do the heavy lifting for the nation to get to zero, not just London. It's a national strategy, it's a communicable disease. And the Mpox thing, I'm glad that came up as well, because that was a national outbreak, almost entirely contained within London. And I say contained because those few vaccines that we had, a deliberate and contentious and difficult decision was made nationally to prioritise those vaccines into London, to try and put a ring around London to contain it. And we didn't know it would work, and thankfully it worked on that outbreak. However, the massive cost incurred by NHS trusts and sexual health clinics in London for managing those guys with it was a horrific infection that required a lot of care. There was a huge amount of stigma as well that required social support as well as practical support from local authorities. The cost of providing that care by the NHS has still not been paid. Local government cannot find the money to pay that. It was a national outbreak. It should have been met by now by a national funding kind of body. And I think it's just, while we can look at what we've achieved over the last decade or two, the incredible advances that have been made, we can't be complacent that we can continue to improve at that pace if our funding does not start to shift. And on resources, for the Mayor in particular and for the TfL advertising, we did a little bit of 2 weeks of advertising before Pride for SHL just to see what would happen. It does not drive lots and lots of testing. The value for me of having posters that are bland and fairly generic that says sexual health testing is everybody's business and it's for all of London, should take sexual health testing seriously, is it creates that environment of destigmatising STI and HIV infection. And while that isn't that important directly to most people who are at low acquisition risk, it means that when colleagues like Mark do that surgical targeting of communities, particularly, say, Black African communities, they don't feel stigmatised and targeted because of their race when that messaging comes through. It is really important that the targeted work is supported by a background destigmatising message, and I think TfL resources could help us with that. It won't, in a much more kind of indirect way rather than a direct way.
Thank you very much.
Please, and thank you, Chair. Please, that's on the record. So, at the risk of using the wrong, a generic advertisement on the TfL network would help, not perhaps generate people to take HIV testing, but it would help, as far as you're concerned, to reduce the stigma of HIV and other STIs. Is that what you're saying?
Correct, which is critically important if we are going to make the inroads around HIV diagnosis for Black African Londoners. I don't see how we're going to get there unless, if we're just leaning on the really targeted interventions, there needs to be a broader message around sexual health is everybody's business.
Thank you.
And I should say, because you're interested in digital, we do have, SHL does have a small partnership with the main gay men's dating app, Grindr.
I've never heard of it. I don't know.
No. And there is a STI testing button embedded in the app during, and it's geo-fenced around the M25. So gay guys going onto Grindr do get embedded in the kind of menu the opportunity to test, and in addition, partners at a voluntary sector organisation called a community interest company called the Love Tank. They develop pop-up advertising, which Grindr puts out for free, episodically or targeting particular communities. So we are embedded in the main kind of app for dating for gay men in London, and the guys that we tend to pick up there are not the guys that are in the saunas and the venues and the bars in London. They are far more ethnically diverse. They're far more likely to identify as heterosexual, not as gay men, and they're far more likely to live around the edges of London rather than in the centre.
Thank you very much for that. Thank you.
Thank you. Thank you. So can I now thank our guests for attending this morning and for their answers to our questions. We will now take a 10-minute adjournment before we welcome our second panel of guests. So I want people back at 11:16. Thank you. I'll do that again. Welcome back to the Health Committee, and we welcome our second panel of guests. We have Mark Santos, who is the Executive Director of Positive East, Joel Robinson, who is the CEO of Spectra, Tony Wong, who is the CEO of the Metro charity, Kat Smithson, who is the CEO of the British Association for Sexual Health and HIV, and Judy Otti, who is the Head of HIV Services at the Africa Advocacy Foundation. Welcome, and welcome all to City Hall. So I'm going to start off with my first question. I'll start with Mark. So what role does the voluntary sector play in delivering HIV prevention initiatives in London?
I think what the voluntary sector does is around that connection with communities that statutory provision cannot reach, and it's about the culturally competent service delivery. It's about the fact that we have the relationships of trust with communities to be able to reach them and work with them and engage with communities. It's about the fact that we involve communities that we're working with in the design and delivery of our services, and in terms of how we message and work with people, and how we will shape services around the needs of people and how people want to access them, taking services out to people. So, for example, with Positive East, we do across North East London, we deliver 50 different venues a month: HIV, STI, and bloodborne virus testing. We will be going out to community venues and community spaces, whether they be libraries, markets, some parks, Tower Hamlets Cemetery Park, for example, Abney Park, taking out services to where people are and where people live their lives, and also to be doing things with community groups. And community events. So there's a thing happens in East London called the African Nations Cup, where different football groups come together and from different African people of different African heritage, and will work, have a tournament, and we'll be there doing testing, doing specialist pop-ups. So we work with Sex Workers Breakfast to do a HIV testing clinic and provision of other resources to people in settings like that. We're also part of the voluntary sector with partners at Metro and Spectra, delivering the outreach and engagement arm of the Do It London programme, and again going out to various venues across London to do that. So taking services out to where people are. Projects like our Women for Women project, around a PrEP equity project that we have, are involving people, involving women from Black African, Black Caribbean communities that are not benefiting as much from the good news about HIV, that have issues about access to PrEP, training people up, volunteers from those communities up, to be able to go out and take and to reach into their social networks, their faith networks, their friendship networks, take information out, and also bring insight back to how services can be shaped better to be able to put people to be able to access them better. And, you know, gives us and underlines some of those points that you were hearing yesterday, earlier today, around for example, accessing PrEP in pharmacy or in GPs or in community spaces. Doing work with faith communities, so we've created faith resources, Islam and HIV, Christianity and HIV, enable us to we've co-produced those with those particular faith groups and use those as an opportunity to have conversations with people, because significant numbers of the people we want to reach are people of faith. As well. So it's a real, the voluntary sector can get to places and parts of our communities that others can't reach and connect because of our cultural competence, because of our relationships of trust, and because of the flexibility we have and the involvement we have with communities.
Thank you. I'm going to turn to Joel. So can you tell us more about maybe the impact of the work of the voluntary sector?
I think building on from what Marcus said, our services are often peer-led, and why that makes that different to the statutory sector is that we can build trust in a way and sort of congruence. So, for example, Spectra does a sex worker project that's basically trains peer sex workers to give HIV tests to other sex workers, and a big problem with that part of our communities is there's just a real fear and sort of lack of, in a way, confidence in terms of our statutory-based services. So sort of coming into, places where there are doctors and nurses, people experience a sort of multitude of kind of, I suppose, like microaggressions and slights about the lives they live. We work with a very diverse group of sex workers, so often people from black and global majority communities, trans communities, and when we can do the peer-led services, it's like we can be outside of a role of what a doctor and nurse can do. So we can be often like more of an emotional support and able to see also the person in their entirety. So often people don't prioritise their health for lots of different reasons. Sometimes it's not just because they don't have access to information. It could be because lots of other things are going on in their lives. Where you get your next bit, in terms of earning a living is often, for example, with sex worker community, really high in their minds. So, yeah, I think what we do is, what we'd like to do is work more alongside our statutory partners so that in a way we can often do something a bit more holistic, but we can also warm up the offer of other partners. And the voluntary sector works hard on that, and mainly we work hard on it because we have less resources than our other partners. And that's, with Fast Track Cities initiative particularly, I think that's been particularly good at placing resources with the voluntary sector and helping the voluntary sector talk to the statutory sector so that we can get the more sort of medicinal parts that are delivered by the statutory sector, often access to treatment or PrEP, and then we can help the communities understand what those things actually are, speak in their terms and their language, and just reach them where they're at.
Thank you. And Tony, do you have anything to add to that?
I think most of it's probably been said actually by Mark and Joel. I think what I would just emphasise is the role of the voluntary sector, as Mark has said and as Joel alluded to, is one that is more relational than I think that other partners are able to offer. And I think what we're seeing in light of that is, people living with HIV often have other challenges in life, whether it's due to their migration status, whether it's due to their sexual identity, their gender. So all of those compounding factors do provide barriers in being able to access services in other arenas, whether that be clinical or otherwise. And I think what the voluntary sector does is offer an outlet for certain communities, certain members of society to access care in the way that suits their specific needs, as Mark was saying, culturally competent, but very consciously minded of the external environment that those individuals are living in, so that we can create an environment that works and serves that community. And as Mark has said, go out and do outreach into communities where I think other providers aren't able to do that. It's very much you come to us, as opposed to what we do is more the outreach and going to them. So, yeah, and I think the peer-led and the lived experience is really critical, because the way that we develop, not only deliver, but develop our service models is very much with service user insights, with that lived experience. And I think that's what allows us to be so nuanced in the way that we work. So, yeah, I think that's the only thing that I would probably say, in addition to what's already been said.
Okay. And do you have any comments to make in terms of the funding outlook for the sector?
Yeah, I think we all can agree that the funding is not looking good. There's recently been data that we've all fed into that's come to light that's shown that what we're seeing is a significant reduction in funding across the sector. and it's having a real impact on our delivery models and to be able to deliver what's needed for communities. And as I mentioned before, the needs are escalating and growing. I think there's a lot of compounding factors, wider determinants of health that are compounding for people living with or at risk of HIV. So when we're trying to deliver services, you know, we're also having to think about people's housing, also have to think about their, you know, their immigration status, you know, just the basic needs of being able to provide shelter and food are often also coupled alongside their HIV status. So I think with the dwindling of funding, it's just adding pressure in an arena where we're seeing increased level of need amongst some vulnerable members of society.
Okay. Does anyone else have anything to add on funding? Mark?
I would say that there's a big challenge with funding. So statutory funders, and for our work, it's largely local authorities through the public health grant, as local authorities have been really squeezed. So our contract values are either frozen or cut, and they're very rarely full cost recovery. Our Trust and Foundations manager at Positive East is part of a national network of Trust and Foundations officers, and they were looking at what's happening in the Trust and Foundation sector, because we bring in 40% of our income is voluntary income, and of that significant portion is from Trust and Foundations. And over the last 2 years, 250, they found 250 trusts and foundations had paused, closed or restructured or didn't open scheduled grant rounds. And of those, 58 have closed and 44 are either restructuring or in the process of restructuring. And there's an increased competition around that funding as well. So you've got less funding, less opportunities and more challenge. I think what I'm hopeful for, and I don't know, it's just one of my failings as being an optimist, is that the devolution of HIV specialist care from NHS England to the ICB level might present us with an opportunity about looking again about how the NHS can be involved in this space and be able to be involved in funding. And so it's almost that what was needed before is not necessarily what's needed now in terms of how we deliver services, and how that can perhaps not involve the HIV specialist clinics, primary care, and also the voluntary sector. I don't want to just paint a tale of woe. There are some really innovative approaches that have happened. So in our experience, even within this tight funding in East London, where Positive East hangs out, City and Hackney and some of the other funders have done some sort of quite interesting approaches to commissioning, to working with us and co-producing results, which I think co-producing outcomes and taking risks around how we better reach the communities we need to reach to get to that 2030 target. Examples of that I briefly touched on were our Women for Women project, and also a project we run in Hackney called Project Community. And it's also been that what's been really important about that emergency department opt-out testing, as well as funding that to happen in emergency departments, is actually having some money alongside it for voluntary sector support, so that we can engage with and support and sustain those people in their HIV care, which is the re-engagement and sustaining people in care is a really critical part of that work. So that's been really interesting and important. And Joel has already touched on the importance of London Fast Track Cities, for example, in building capacity about in-clinic peer support.
Good. I'm going to turn to Judy and ask about the Africa Advocacy Foundation. So what services do you provide and what impact does your work have? Sorry, if I can ask you just to turn your microphone. Thank you.
Yeah, I forgot that bit. So Africa Advocacy Foundation focuses primarily on migrant communities, predominantly Black African, but Black heritage. And we find very many intersecting issues that these communities face, and these play a huge role in their access to services or retainment in care. And what we are finding is the intersectionalities, whether it's around trauma, whether it's around trafficking, whether it's around other comorbidities that they're living with. How do they manage those comorbidities, and poverty and housing and all these other issues that my colleagues have also raised. And just trying to be as an organization that supports them holistically with the lived experience in hand, and with members of staff that have gone through these same processes of immigration. We provide expertise, care, and a trusted person, a person to handhold them through. I just want to also cite in emphasis to what Mark has said in terms of funding, which we find there've been very good experiences in Lambeth and Lewisham now, where they're breaking down funding to specialistic organizations, and that's good. But what we're finding is they're short-lived, and the impact then is really affected. You've built up a repertoire with your community, and after 2 years, that service doesn't exist anymore. And we're aware that Black communities are the ones, statistically, we're finding are late diagnosed, poor outcomes in healthcare, are disengaged in care. And if we can't keep this momentum, then we definitely will continue to see these results.
And just in terms of the services you provide and what you're seeing in terms of for your organisation, what particular challenges do Black communities in London face in relation to HIV?
One of the major challenges is around culture competence in services. We've done a survey that will be published in February as One Voice Network, looking at experiences in primary care, and a lot of the statistics we highlight will be. It's coming out. I don't want to preempt that, but what the findings came up was services in primary care were not culturally competent at all, and this affected access. It affected the service users not feeling that they are heard, understood, and as a result did not engage. And working together with organizations that have this expertise, I think, is really key. We are finding a lot of service users, especially from Black community, have not told their GPs about their status, purely because they find the experience in GP care is very different from the experience with their consultant. And this is purely around culture competence, a lack of culture competence and stigma in these services.
Okay. When do you think you'll be in a position to share that? Because I think we'd be very interested to see that.
We are launching it mid-February, so we'll definitely share that with you.
Thank you. I think that will time in well with this committee's work as well, so look forward to receiving that in due course. And in terms of further action, what further action would you like to see in London to ensure that HIV services are targeted towards and supporting Black communities?
One of the big issues we're finding is, again, around the funding model. Funding model is borough restrictive, and yet, Mark talked about the football tournament that's coming up. But what we find in Black communities, especially, they congregate from all over, across boroughs. And if we are restricted in terms of how we spend our funding in particular boroughs, then we are not really serving the community well, holistically, to meet the various needs that they have. And we know transmission doesn't necessarily choose which borough it wants to occur. So we have to be more flexible in these models of funding.
Sure. Mark, do you have anything to add on that? Yeah, sure. Thank you. I'm going to turn to Assembly Member Boff.
Just very quickly, just to get this on the record, could you give us an example of the lack of cultural competence? Because it's a bit of a buzzword, and without an example, people might feel that they don't understand what that is.
No, sure. I'll give you an example that's cited in this report, where somebody of Muslim faith goes to speak to their GP. The GP is recommending treatments and support that do not align with their faith, and there's a real lack of understanding in terms of the barriers in taking up of services because they don't meet their faith requirements. There are simple things around in certain cultures where a female is not necessarily comfortably being able to be seen by a male doctor, for example. What facilities have been put in place to support a patient like that, where they're talking about intimate issues, but culturally or for religious reasons, they cannot convey that information to a male doctor, for example.
Thank you very much. That's spot on. Thank you.
Thank you. Assembly Member Best.
Thank you. Good morning, Kat. I just wanted to come to you and ask from the British Association for Sexual Health and HIV, what's your kind of take on the key challenges facing reaching the 2030 targets in London?
Yeah, so for a little bit of background, the British Association for Sexual Health and HIV, we represent the genitourinary medicine workforce, so a lot of the people delivering clinical sexual health services, so services such as the Enfield service that was mentioned in the previous session, and we represent people across the multidisciplinary team delivering those services and working really closely with the voluntary and community sector who are here represented on this panel with me as well. I think there's a lot of challenges that these services are facing, and I hope you'll forgive me if I paint a maybe slightly negative picture kind of the current situation. It is really important, I think, to remember that you cannot separate HIV from sexual health and sexual health services in many ways, and a lot of the discussion and talk about HIV, which is really, really important and critical. There's a lot of talk around HIV care and support, but a lot of the initial kind of, I suppose, the prevention, the testing, and everything. This is all happening within sort of at an earlier stage of the care pathway, and it's being commissioned through the public health grant, and it's also happening largely within these sexual health clinics that are facing huge challenges. And that is being seen in sexual health outcomes as well. In terms of what the contextual challenges are, I think there's sort of 4 key areas that I hear a lot about from members. There is obviously a huge strain on resources, but also, I suppose, the suitability of some of the resourcing framework as well. So a lot of our sexual health clinics in London are on the integrated sexual health tariff, which is really beneficial in lots of ways, and there's lots of good things about it in terms of the money following the patients, but it is a tariff that was designed and developed quite a few years ago based on different kind of needs, and again that's reflected then in my second point, which is around really changing demands and needs, which have been talked about really clearly by my voluntary sector colleagues here as well, and actually that being reflected in more complex STIs as well. So the complexity of some of the clinical kind of challenges that my members are seeing is really changing, but the resources aren't following that complexity necessarily. And that,
Kat,
sorry,
before you move on,
yeah, of course.
Could you expand on that point around what that means when you say that they're becoming more complex, but the funding isn't following it?
Yeah, absolutely. So I think the most kind of glaringly obvious example of that is sort of the significant rise in syphilis cases that we're seeing. So syphilis was at one point seen as eradicated, and we're now seeing the highest cases in the UK since 1948, and a lot of that rise is being seen in London. So syphilis is a condition that requires quite expert support and care. I'm not a clinician, so I'm not going to speak to what the clinical kind of response would be. But in terms of making sure that, for example, you have the right kind of commissioning framework in place, when the integrated sexual health tariff was first designed, syphilis wouldn't necessarily have been on the radar in the way that it is now, because it's sort of 12 years old, that tariff. What we're seeing then is the complexities of syphilis then follows on. If you think about then the impact if you have undiagnosed syphilis, or if you have syphilis that is not being treated in good time, you see increasing rates then in other parts of the community that are maybe not testing as often. And we're seeing cases of congenital syphilis now, including cases that I've heard about in London as well. So this is something that requires real expert care and support, but the workforce challenges, which were going to be sort of the next thing I talked about, really are not compounding some of these issues, because what we have is a workforce in genitourinary medicine which has been subject to really significant cuts because of the pressures on the public health grant. There is quite low morale amongst that workforce for various reasons, and what is seen as a potential kind of hollowing out of expertise as well. We're taking actions as an organisation to really support and promote the speciality. So we have a Love Gum campaign, which is all about introducing more people coming into the medical profession to gum and to what it can offer them as a profession. But we have seen a decrease in the number of people going into this profession, and we really do need to think about long-term sustainability of the workforce and making sure that we have a really strong multidisciplinary workforce that can meet our future sexual health needs and can respond in partnership with the rest of our sort of colleagues here in the room to the emerging challenges. And MPOX is another example of that as well. 10, 12 years ago, we wouldn't have been talking about MPOX, but actually the gum workforce was really critical, working with the voluntary sector to actually enabling a really strong response to that. And London was, a massive part of that, being kind of the epicenter of the UK outbreak.
Thank you. Just to drill down on workforce, obviously you're saying restrictions or and expertise leaving. Is the workforce challenges all around expertise, or is it in general there's not enough people coming into the sector? And in terms of expertise, what kind of expertise are lacking? The need, where is the needs gap in terms of training, I suppose, is the question.
Yeah, I mean, it's a big question, and I think what it requires is a really strong strategic response. If I focus specifically on the consultant workforce, so GUM physician consultants, we have some of the best GUM kind of workforce and physician consultants in the world. We're quite world leading in the UK in this speciality. Increasingly, though, obviously you need people coming up through the profession, through the training pipeline, in order to take on consultant roles in the future as people retire. And increasingly, we're seeing kind of vacancies in posts in GUM, including some vacancies in London, and that is largely a result of people retiring. Sometimes people also leaving the profession, but certainly in the consultant arm, people retiring. And there is a real need always to be training up new physicians into those posts and making sure that you are giving people the training that they need as well. I think one of the issues that we've got with the way that kind of commissioning has been fragmented is working out key responsibilities for that training pathway and taking a really long-term view. Your workforce needs today, here in this moment, when you're under resource pressure, are going to be different to the workforce needs in 5-10 years. Who is paying to train that consultant physician? But there's also wider workforce needs as well. The physician is kind of part of that picture, and they're an important part of that picture because they provide a lot of the oversight and clinical governance with which the rest of the multidisciplinary team sits. But they also work really closely with, for example, sexual health advisors, with a really highly skilled nursing profession within GUM, who also have consistent training needs and who need to be kind of developed. And that is where we have seen some of the impacts of kind of low morale and instability in the workforce. People kind of potentially moving either out of London or moving into different areas of the NHS and things, sometimes as a direct result of some of the pressures that they've been under within their services, responding to tenders, for example, trying to respond to the huge funding pressures. So it's a complex picture, but it's one that requires quite a strategic solution and one that involves the whole multidisciplinary team.
Is some of that workforce pressure driven by commissioning periods and obviously the knowledge that there's been, in public health grants, big cuts? Is some of it driven by perhaps the staff believing this is perhaps an unstable career? There's similar careers I could go into which might provide more stability, and perhaps could those be addressed by the commissioning periods being longer, or is there another way? Is that part of the problem, or no?
So we have done a little bit of research in particular in relation to our Love Gum campaign to kind of look at the changes to people kind of coming into the profession, and the evidence does suggest that I think concerns about the tender process and about I suppose the stability of services that you might be going into, as well as what these processes might mean for you in your role, is something that that people do consider going into that profession. It is also something that does have a significant impact on people working within those services in the here and now. And I say that with the greatest respect also to local authority colleagues who are under a huge amount of pressure as well. The cuts to the public health grant, I think these such sort of resource challenges, they exacerbate, though, other issues in the system. And I think, yes, tendering and thinking about the stability of a role or stability of a service does have a huge impact on people going into the profession, as well as other things. And there is also, I think, stuff to do with thinking about, what does a GUM physician do compared to, for example, community sexual and reproductive health. And we've been doing quite a lot of work to really explain and do more to kind of get across why GUM physicians, what their sort of specialism is, and also the significance of that to the HIV workforce, because our GUM and HIV specialists are the people who are also delivering complex HIV care as well. So although that a lot of my members are based within sexual health services, they're also delivering HIV clinics, and as physicians they're going to be really involved in delivery of complex HIV care. And as we have an ageing population with people living with HIV, that's also really, really important to the HIV response as well.
Thanks. So we touched on a lot of the main challenges services face from commissioning from local authorities. Obviously, a lot of it boils down to resources, and unfortunately, this committee can't really wave a wand and get that money present. But I think Judy was touching on it a bit with how the way in which some things are commissioned and what you're allowed to do with that money. Is there anything else that you would add where we can kind of make resources go further, or make it easier for the voluntary sector or services to use that money to affect wider change, more effective change?
Yes, I think that, as you say, you can't wave a magic wand and put more money in the system necessarily. I think we should be, we need to make the point about resources because it is a key factor. But also as I said, resources exacerbate systems challenges as well, and we do need a systems-based approach in response to this. I think one of the biggest issues that sexual health services face, and one of the things that my members raise quite a lot, is the sort of fragmentation of different services and sort of siloing, and also the drive for cost effectiveness, or perceived drive for a cost effectiveness, rather than kind of looking at how new innovations need to be an addition to and support existing services. I think Adrian in the previous session was talking about how online services cannot meet the needs of everybody, and they play a really key role, but did refer to the fact that it is a cheaper form of testing. It's really, really important that online services are developed and exist, and my STI members are really keen on online services, but how do you look at that as part of the system as a whole? It doesn't exist, end-to-end online services do not exist in a silo on their own. People need to be able to access the right face-to-face services at the right points. So it is all about integration and a systems-based response, and making sure that we are considering how increasing resources for certain aspects of the system might impact on other aspects of the system as well. So, where are we taking resources away from one part of the system in order to resource another part, and is that actually the best thing to do for patients?
Thank you. And just finally from me, in London, in your opinion, are we on track to meet the 2030 targets?
When you look at the situation with sexual health, and you consider that you cannot completely separate sexual health and HIV, and you look at rising STIs, and you look at the pressure on sexual health services, I think it's impossible to say that we are on track to reach 2030. What we would really like to see is a concerted effort, I think, to really recognise where we are with sexual health as part of this as well, and really think about what we can do to ensure that our sexual health services are also being supported to deliver for Londoners. Sexual health and STI rates are in and of themselves a really significant and important health inequality that also needs to be looked at, but it really does come hand in hand with HIV, and the two are the two work together in a symbiotic. So I think it is very difficult to say that we are on track when we're seeing deepening inequalities, and that's coinciding with rises in STIs in general, such as gonorrhea, chlamydia, and rises in complex STIs such as syphilis too.
Thank you. Assemblymember Boff.
You've conveniently, in your last paragraph, answered my question. So that's lovely. So I can perhaps ask something a little different. Do you think, particularly with regard to Mr. Robertson and Mr. Santos, the work that you're doing with sex workers, is that are you offering a broad range of services, or do you focus particularly on STIs? Because of course, many sex workers require quite a range of services.
Yeah, I would say the sexual health element forms a sort of maybe like a quarter of the work that we're trying to do with sex workers, and I think really the needs are often advocacy in terms of people need to understand the law. They're worried about prosecution. There's a new law that's really impacting trans sex workers at the moment, which is that basically people have to declare their gender identity at birth when they have sex with somebody in order to gain consent. And so that law has just changed, and we're doing lots of advocacy basically with the community to say you'll put yourself in a vulnerable position around consent. So things like that are changing all the time, and obviously the wider political situation for sex workers and other marginalised communities really impacts.
Fascinated by what you just said, and I have to admit my ignorance to that legislative change. So I would be very grateful if that's something you could submit to the committee offline so that we can.
Certainly, the CPS has just changed its guidance.
It's guidance or law?
It's now law, and we've had a number of people arrested in the last couple of weeks. So we know about 6 people who've been arrested. So yeah, we're very worried about this kind of thing, and that's predominantly what we look at with sex workers, is that that kind of advocacy.
Yes. And do you work with other agencies as well, things like National Ugly Mugs or anyone like that?
Yeah, we Spectra has a kind of fairly large grant to work around a sex worker coalition building. So we work with National Ugly Mugs, we work with a range of sex worker organisations. But what I would say is, particularly around sexual health, kind of sex worker organisations are really, really grassroots and really underfunded. And so, because predominantly people look at a rights-based approach and an advocacy approach, kind of HIV and sexual health inevitably becomes a slightly lesser sort of concern. So an organisation like Spectra, which is focused on sexual health and HIV, we're really keen as part of the coalition building to make sure that those organisations that work with sex workers can kind of grow their health work, because, you know, it is a very sort of specialist area and a sort of specialist kind of outreach in a way into communities. And I know Mark mentioned that Positive East do this work. But, you know, really what I would say is, having been a professional in sort of HIV sexual health field for a long time, that particular marginalisation of being part of a sex worker community is probably one of the least resourced in terms of, you know, when I look at all the programmes that we're doing, when I look at the 2030 goals, that community and other really quite smaller marginalised communities, for example, trans and non-binary communities, they're really, we're really behind in terms of, you know, giving good advice and resource around sexual health. And, you know, really their experiences, we've written a couple of policy reports on sex workers' experiences of sexual health services, trans communities. They really struggle with just accessing good non-judgmental support from particularly the statutory sector. So we'd love to do something more, and we are often offering training to our statutory sector colleagues, just because they're really keen to be more inclusive of, you know, the communities that we know we have to reach if we're going to get to the 2030 goals.
Thank you. Mr. Chair, we're well ahead of time, so I'm just going to have another tangent as well. I think perhaps to Ms. Otti first, and perhaps if somebody else wants to answer as well. To what extent do people who have no recourse to public funds affect the services that you provide to them? To what extent is that a problem?
First of all, they're very complex cases that come with the no recourse to public funds. That might just be one of the issues they're facing integrated with their HIV status. But trauma plays a big role in terms of maybe why they're here in the country, or the experience they went through to come here, being away from their own family and social networks. All those play a role in terms of how they engage in services, how they comprehend relationships and information that we relay with them. So all of that compounds in terms of funding. When you're now looking with the funding we are receiving is mainly around HIV, either support or testing, but may not look at mental health or counselling or all these other complex issues they're facing and how we have to support them. So we have to look for additional funding to support those needs. And again, it comes down to fragmented funding that is not long-term, and therefore you can't have consistent services that are supporting the people you're supporting.
And perhaps to Ms. Smithson as well, you talked about the tariff earlier. Does that tariff get affected by treating somebody who has no recourse to public funds?
My understanding is that that's not the case. So with regards to sexual health care, it is open access to everyone, and HIV care as well. This is and I might not be the best person to speak to this. I'm sorry, Judy can refer to it as well. HIV care is also freely available to anybody in the UK, regardless of their immigration status. However, that's not necessarily always understood. And I think ensuring that people do understand what they what they can access for free is a really key role, I think, for our voluntary sector colleagues as well, and something that they put a lot of time, effort and resources into to support people into care. So that's a way that our clinical services work really closely with the voluntary sector is, access to services isn't just about where they are positioned in a borough. It's also, does someone know where they are, if they can go there, and how to go there safely. And that's where we have to work with partners to really kind of make sure that the information is getting to people through the right networks and in the right ways.
Thank you. So if I'll say something, Ms. Otti.
No, just to add to what you're saying. So they are free, but again, if a patient has other health conditions that they are facing, which is in most cases what happens, especially with people who are living with HIV for a long time or who are in poverty and have then, as a result, experienced additional comorbidities, the HIV treatment is free, but the treatment for the other comorbidities is not. And that creates a tension in terms of adherence and management of their quality of life.
So is it fair to say that the level in which you intervene, that no recourse to public funds is not an issue, but it's what they then go on to receive is going to be an issue for them? Is it a fair statement to make in the case? Thank you very much. Thank you, Chair. Oh, sorry, Mr. Santos.
It's just underlining that point that it doesn't impact on what we offer, but it might impact about how people access those services. And so that whole issue about building relationships of trust with people is quite key in enable them to be able to access the services to which they are entitled. Just to underline that point. And it just made me think about when you were talking about trauma, that's a key issue for people who are here as a result of forced migration and actually other particularly women, because of the link between HIV and gender-based violence and trauma, and being able to address that is key in being able to support people to live well with HIV. And access to mental health services generally is patchy and poor. And it's why, for example, like other charities, we've got a counselling service, and why we've got a specialist psychology service for women who've experienced trauma.
And finally, I feel like I can do this because we've got tons of time. Assemblymember Wilson's next. I'm sure you'll wait a little while. With regard to victims of trafficking, how do your organisations identify those victims of trafficking? Because it ain't easy.
Again, it's about that relationships of trust that we have with people, and working with people and seeing, and then over time you'll...
I understand that. I understand that. But how do they know where to go to? How
I understand.
You see what I didn't ask it very well. How do they know how to access your services?
I think that becomes a more tricky, but there's a variety of ways that we get our message out, and some of that is through communities and through community networks, to making sure that people know that our services are available, and that this is a safe place to come and have those conversations. And I think that would probably be one of the key ways. Or sometimes it's opportunistic or accidental, or people have got out and come to talk to you, and then you realise what the situation is, and then can link them into the appropriate provision. So I don't think it's particularly systematic or easy to do.
And just put a little bit more. Do you work with the statutory services who also have an interest in ensuring that there are services available to trafficked people? I mean, some years ago, one element of trafficking is people being brought in for domestic service and effectively trafficked in. One of the initiatives that was done at the ports was to ensure that individuals coming with families are given information in languages that they could understand about where to go should they need arise. I mean, have you been working with those? Do they engage with you?
We haven't specifically, but we do work with the local safeguarding teams in the different local authorities. I don't know if other colleagues have done.
Thank you.
No, we haven't, but in AIF's experience, because we are an organisation that supports Black Africans, people do come to us, and they may not initially say they've been trafficked. We have a situation, and it came in as drug and alcohol abuse and homelessness, and that's how they presented. Eventually, we understood there were issues around trafficking and a diagnosis of HIV and all these other things. But the initial presentation was around drug and alcohol support and homelessness.
Yes, Ms. Marsden.
Yeah, I think that initial presentation thing is really important. So recognising that the reason why somebody might be sat in front of you in the first place might not be how they leave. Essentially, it might not be the service that they leave with, and that is something. We were talking about rising demand and complexity. A really key factor in that as well is increasing numbers of people who might present to sexual health clinics with sort of a symptom or with one kind of thing that they want to address, but actually end up being identified as having more complex needs potentially. For example, increased psychological needs. There might be indicators of intimate partner violence and things like that. And these are all kind of safeguarding things that clinics are used to managing but are seeing at increasing rates. And they need to be able to effectively signpost, refer and work with their voluntary sector colleagues as well to enable them to properly support that person. And these are areas where having that, that skilled workforce and multidisciplinary team is even more critical. But it's often those kinds of wraparound services are more that they're often the first things to kind of go when you have funding pressures, and particularly if you look at kind of the sexual health advisor role and the part that they can play in that. Those roles are under increasing pressure especially when you consider that a lot of that isn't necessarily covered by tariff stuff, because they're potentially, I suppose, more the outputs and activities are more difficult to kind of quantify.
Thank you very much, Chair. Thank you.
Thank you. Our next question is from Assemblymember Wilson, who's joining us online.
Thank you, Chair. As with the last question I asked to the previous panel, this is a fairly sort of broad, all-encompassing question, and welcome the thoughts of any of the members of the panel that would like to jump in and answer it. But picking up from, I think, Kat, in your reply to Assemblymember Best, when you said at the moment it's impossible to say whether we're on track to meet the 2030 target. With that in mind, what further action or steps would you like to see take place in London that would either give us a bit more certainty as to whether we can meet that target, and also to help us indeed meet that target by 2030 for zero HIV?
Yeah, I think, as I said, that there is a real need for a systems approach to this, and to really think strategically about how we address HIV and sexual health together and not separately as well. And I think nationally, there is a real need for a more strategic approach to sexual health. We haven't had a national sexual health strategy for many, many years, and there have been various commitments for one that have been long grasped, and it really is important that we start to take this issue seriously and think about what a strategic approach to sexual health across the UK, but particularly, today we're here talking about London, looks like in 2025 onwards. And I think London does have specific needs and a specific approach, but it also can't be looked at completely independently of the rest of England or indeed the rest of the UK. So it is really important that we think about what we might do in London that might then support national action on this issue, and also that symbiotic relationship between London and other parts of the country. But really what we need is a strategic response. We need to look at actually what are we seeing in terms of sexual health outcomes, including in HIV? What do we know works? What's the evidence base? And how do we make sure that we have the workforce and the services there to address those, to address the challenges that we face? And what we would like to see is definitely HIV and sexual health being looked at together, because we won't achieve our goals in HIV if we don't look at core fundamental clinical sexual health services that really have underpinned the HIV response alongside the voluntary sector for many, many years. So that is, it's a convoluted answer, sorry, but it really is about having a strategy in place.
All that Kat said, and the addition to for me would be around occasions like this, or like the London Assembly holding a spotlight to HIV and HIV in the city, and keeping that very much on the agenda, and that also not being just about prevention, but actually supporting people living with HIV to live well and promote the quality of life for people living with HIV, because I think that's quite important in sustaining people in their HIV care, and also where people have become disengaged from HIV care, which is a sizable section of the community, that we support them to be re-engaged within their care. It is holding ground on some of that statutory funding. If we can encourage, if you can encourage colleagues in local government to in this last mile around getting to 2030 to hold the line, that we need that funding to be able to achieve that. And maybe I was just reflecting on what Kat was saying about some of the procurement and tendering that happens, that how disruptive that is, even for bigger organisations like trusts, how much of a distraction that is from the delivery of services and proper planning. There must be alternate ways, and I think the new procurement rules provide us with opportunities maybe to approach approach commissioning very, very differently, and also touching on Julie's point around longer contracts. Often we'll get projects for a year, and you'll be just setting up by the time you have to wind down, and doing work with some communities that are unheard and whose voices are unheard. It's going to take a lot longer than a year in building that trust, developing those relationships, and moving forwards. And also, my final point would be around the the devolution of NHS specialised funding to ICBs as an opportunity to see how we can work differently to address the needs to enable us to get to where we want to be in terms of those goals.
Yeah, and maybe just to add to what you're saying, it's also looking at the significance of community-driven approaches and looking at the role that community organizations play. I'll give an example of a community outreach project we're doing in Southwark called CASH, Community Access for Sexual Health, and it's a project running for 1 year. It's finishing at the end of March, but we've got 2 positive diagnoses since who knew their diagnosis, did not believe it, and have not engaged in care. And they just came to the testing centre because they thought, oh, let me see if I'm still positive. I think I've prayed and I've been cured, or that must have been something that I didn't trust. And we've been able to link them back into care, help them with understanding their diagnosis, help them with understanding that there's a face to positive living with HIV. And these are something that community can do that cannot be done by statutory organisations.
Thank you. Assemblymember Boff, you had a question.
Yes, please. To Ms. Smithson, you talked about strategic response being really important, and when you're allocating, but in order to allocate resources strategically, you need to have the data to back that up. Do we need a needs assessment for sexual health services in public health services, but sexual health services in London?
I think what we would say is if doing a needs assessment, it really does need to be holistic. So I think there's references to needs assessments in London in the context of sexual health and HIV, but often they, my understanding is that they're often commissioned through quite a sort of narrow lens. I think that it would be helpful to look at the, look now today in 2025 at the sexual health epidemiology of London as a whole, and also to think about the individual needs of our communities from a sexual health perspective as well. I think it would be a large undertaking, but it would be very valuable. But it must be holistic, and it must also include it must look at community services and clinical services, and what is needed in terms of what's actually achievable. So there's what people want, there's what they need, there's what the evidence shows works, and yeah, I think that there's a lot that could be very valuable in that to kind of lead us to a position where we are potentially designing something in a system which does meet needs today.
Do you think the Mayor of London could use his advocacy role to promote that? Because, as you so rightly said, such a needs assessment is a big undertaking. Is that something the Mayor could lobby for?
Yes, I do think so, and I also think that what would be really, I think it would make a huge difference for the Mayor to talk about sexual health as well as a massive issue that is impacting on Londoners today. I think that the Mayor's advocacy around HIV has been fantastic. I was there when he signed up to HIV Confident, and it is, it's so important, and it does make a difference. And I think it is helping to showcase London nationally and on an international stage in terms of the progress being made on HIV. So I can see that there could be real benefits and impact of the Mayor also talking about sexual health and talking about the challenges and inequalities that we're seeing in sexual health for Londoners as well, because this is a major issue that is affecting the city.
And finally, I asked this of the previous panel as well. Do you think there would be some value of using the TfL estate to promote the public health messages, either through destigmatising those things like testing, or promoting positive public health messages? Because currently there really isn't a lot on the TfL estate promoting those messages.
I will refer back to my my health promotion colleagues and who are experts in that area, marketing.
That was to everyone.
Yeah. Okay. Good. Yeah.
I think you've heard quite a bit about the Do It London programme this morning from Mark, and I think one of the major issues is that the Do It London programme is sort of a very broad and kind of generalised message about HIV, and it just doesn't have enough funding to be able to run kind of tube adverts and things on buses. It has.
I'm not proposing you should pay. I'm proposing that the Mayor of London should make available a proportion of advertising for public health messages.
I mean, it would be amazing if that happened, because really we struggle with HIV in particular being an issue that is just not forefront in people's minds. And I think, we still struggle very much with Victorian attitudes towards sex. So having, posters that really address good sexual health and HIV, they feel like they should be for the 21st century, don't they? But but they're not really yet. And, you know, we're mainly working with, although there's an ageing population living with HIV, we're mainly working with a lot of young people who they never saw any information about HIV when they were growing up because they weren't born. And so, you know, I know something like EastEnders, you know, that in a way has a bigger impact than unfortunately many of our health programmes do. And so should it, you know, it comes into people's homes. So when I think about London and, you know, where I pick up messages and just the frequency that happens in terms of, you know, people's contact with the TfL estate, I think it would be fantastic if there were resource put there. Yeah.
Thank you very much. Ms. Otti, yes.
No, just to also add, it will help to normalize these conversations, because a lot of times this is what we're struggling with, and that's what drives the stigma. But just that presence in your everyday life will normalize, and I think that will then bring in more people to take action.
Mr. Wall.
Yeah, just to reinforce those points, I mean, I'm about 4 months into my role at Metro, so I don't have the legacy of knowledge that my peers do around HIV specifically, but I have worked extensively in other health arenas, specifically prostate cancer. And in that lens, we ran health promotion through outdoor advertising, bush shelter advertising, and the uptick, and it was specifically targeting black men. So there was a synergy with the work that we do in terms of HIV context, because black men have an increased risk of prostate cancer. And through health promotion, through outdoor advertising, we were able to massively impact the number of black men coming to Prostate Cancer UK at the time, requesting health information, taking positive action around their prostate cancer health, speaking to the nurses, and going to visit their GP. And I think the same issues that persist around prostate cancer are relevant to HIV in terms of the stigma, particularly in certain communities where there is a misconception about how transmission happens with HIV. And you talked about Judy talked about cultural competency. I think one of the things that comes to mind when I reflect back at my time at Prostate Cancer UK, and I'm sure it's relevant in HIV, is this, I think Judy alluded to it, there is a notion within some communities that you can use faith as a way to heal from, without needing medical intervention. And I think unless clinicians have that awareness that that is a potential risk factor for certain communities, they can be lost. And I think this is the value of the VCS, is that the relationships that we hold often go beyond that one diagnosis, that one issue. So even though they may not be engaging with that specific issue, there often may be still a relationship that we can still build around that individual that brings them back in. So yeah, I guess I picked up on that point, but going back to your question, I think, yeah, if the mayor could put some money behind a national campaign, and I think, I am old enough, I was around, but probably not old enough to actually remember the 80s campaign, but I've seen the legacy, I know the legacy, and I think, that legacy, for me, shockingly, still plays quite a big role in what the challenges are in terms of people living with at risk of not being able to navigate the system through fear of people finding out that they have HIV. And I think in 2025, 21st century, 2025, I think that's horrendous that we are, 40 years later, and we still have the legacy of what was quite a negative, government-led campaign that targeted certain communities. And so I think if there's anything that the mayor can do to kind of combat that, I think it will pay dividends in the work that we do. So thank you for that question.
Thank you very much. Thank you, Chair.
Thank you. Can I now thank our guests for attending today and for their answers to our questions. We will now take a 5-minute adjournment break before we welcome our last guest. So back in at 12:31. Thank you. Welcome back to the Health Committee. Joining us online for our third and last part of the meeting is Dr. Elske Hoenenberg, who is the head of the Centre for Sexual Health, Public Health Service of Amsterdam. Welcome, and thank you for joining us online today from Amsterdam. So the first question is from me. Can you give us an overview of the actions taken in Amsterdam to reduce the number of new HIV infections?
Thank you for the invitation, and very happy to share our experience in Amsterdam. We have an Amsterdam City strategy to reach 0 new HIV infections, and it contains 5 pillars: increasing PrEP access, low threshold HIV testing, including self-testing, immediate linkage to care and treatment, addressing stigma, and sharing our knowledge with partners in the Netherlands and abroad, and also learn from other front runners and front runner cities like London. And I think with the follow-up questions, I can give some more insights about the actions.
Sure. Just asking about the test and treatment strategy work that you're doing. Can you give us a bit an overview of that? And do you feel it could be replicated in other cities such as ours in London?
Well, I'm very impressed with London and its testing strategies. London's very good at low threshold testing, and what's also good in London is the NHS system involving testing and treatment at no cost. So we're a bit jealous about that, because in Amsterdam we have our deductible, so testing costs usually are part of the deductible. So that's out-of-pocket costs of 385 to 900 euros when someone tests through a GP, for example. However, in Amsterdam, we do offer free of charge testing at sexual health clinics, so at no cost at all for the person. It's open for key populations: young people, trans persons, sex workers, men who have sex with men, and people with symptoms of an STI or of HIV. These centers are real experts, expert clinics in sexual health. They do offer more than just HIV and STI testing, like counseling, support and linkage to care after sexual assault, contraceptives, and much more. For gay and bisexual men who only want HIV and STI testing and with no symptoms of an underlying infection, we also offer online service where they can go to 10 clinics in town to bring their samples. And next to that, we do some outreach testing as well. All care can be provided without revealing one's identity. I think it's the same in the GAM clinics in London. I think that's very important for some people. This exception is also included in our legislation. We perform extensive surveillance of our testing outcomes, and we can then adjust our programs to reach those most vulnerable or most at risk. So in addition to the sexual health clinics, people can test for HIV at their GP, professional or commercial clinics, but that's at higher costs. And then we do have programs for special populations. For example, newcomers, asylum seekers. We offer like meetings. It's like a party atmosphere with music, food, performances, but we also provide information and testing there. And I think that's a very relevant program because that's a group that we do not reach very easily otherwise. And for sex workers, we have a clinic right in the middle of the red light district with adjusted opening hours to accommodate sex workers. Extensive outreach, both online and also offline. So we visit the windows and offer a test right away. And we do involve key populations, mainly sex workers, in our programming. And then to conclude for this point, I have an example about our data. We do have quite good data on HIV outcomes. We collect that and by our government-sponsored HIV Monitoring Foundation. And one of the recent findings is also a publication it's we call it the Athena cohort. They do quite some very good scientific research with the surveillance data. So they had a publication about PrEP, and they showed that so that's nationwide data. 16% of persons with a new HIV diagnosis from 2018 to 2022 had used PrEP prior to their diagnosis. So it indicates that we have to improve retention in PrEP programs and re-engagement, because this is really sad that people indeed were linked to PrEP, were using PrEP, and still got an HIV diagnosis later on.
Thank you. Just on PrEP, my colleague, Assemblymember Boff, is about to come in and ask questions on PrEP.
Sorry, we're still probably a bit staggered here that somebody has to pay €385 for treatment, but that's that's alien to us in the UK. But with regard to PrEP, you said something. Your last sentence was that some people were on PrEP but contracted HIV. I don't want that misunderstood, because I found that confusing.
Yeah, thanks for the clarifying question. So if someone is diagnosed with HIV, the doctor in the clinic always asks, have you ever used PrEP? These data is collected, and then what we saw was in people with an HIV diagnosis between 2018 and 2022, there was 16% who said that they had used PrEP somewhere in the period, in the prior period. So it could be a PrEP tablet from a friend, but we do know that some of these people were really engaged in the PrEP program, were taking PrEP, and then for some reason stopped. Life circumstances, a relationship, didn't feel at need anymore, didn't re-engage, and then subsequently contracted HIV.
So we can't say that those people were regularly using PrEP and still contracted HIV as people who probably had a period when they didn't take it that may have been the reason.
Yeah, that's correct. They didn't take it for a while. We do have some incidental cases of people who use intermittent PrEP, like around sex, and they are in the program and are diagnosed with HIV because they didn't use it correctly. But that's not very common, luckily.
Thank you for clearing that up. How has Amsterdam been successful in improving PrEP access, particularly amongst the most high-risk groups? How have you promoted that?
Yeah. So in our sexual health clinic in Amsterdam, it's a large clinic that performs about all PrEP and HIV STI testing together, about 60,000 consultations on a yearly basis, and about 10,000 of those are PrEP. We try not to use the word risk too much because of its negative connotation, and we try to focus on people who live in vulnerable life circumstances and are less likely to get care elsewhere, because our sexual health clinic is indeed very large, but we cannot provide all PrEP care in the whole of the city. So we do it in addition to care at GP clinics. So people can choose either go to the GP or to the sexual health clinic. And I think it's good we do it together, and it's good that we focus on the most vulnerable. So we prioritize young people under 25, we prioritize people with a migrant background, people without insurance at all, sex workers, trans people. Because these groups either have less financial possibilities or are less well informed about the Dutch healthcare system. Young people may be afraid that their parents find out that they are taking PrEP when they go to the GP. And there may be more stigma among these prioritized populations.
And you talk about that stigma. How can someone get PrEP in Amsterdam? What bureaucracy is there prior to somebody being able to access PrEP?
In a way, it's quite like a low threshold, because you can make an appointment at the sexual health clinic, tell them you want to tell us you want to use PrEP. We will check eligibility, knowledge, your HIV status, and then you can get PrEP. We are kept in our number of PrEP users and our financial situation. So we cannot give it to anybody. So we don't have large billboards outside saying, please come here for PrEP. And also in our communication, we do say, so you can come here, but for people over 25, for people who have a good relationship with their GP, please go to your GP. Let's do it together.
One of the questions I asked earlier of the London professionals is that still in the UK, and it sounds like in Amsterdam as well, you just can't go and buy it without some kind of medical authorization. Is that correct?
That's correct. Also legislation, it's medication. A doctor needs to prescribe it, and a doctor needs to ensure you understand how to use it and you're HIV negative. Basically, that's it.
And as I understand it, you've had a substantial decline in new HIV infections. Do you think this has got something to do with the fact that PrEP is free under most of the health insurance plans? Or is it not free? I think
it's not free. It's
not
still
free.
Part of this deductible. So of all health costs, in a year, the first €385 you pay for yourself. PrEP is now about €18 per box of 30 tablets. Yeah. So it's not very expensive, but it's not for free. I do think that the impressive decline in new HIV cases we saw in Amsterdam is multifactorial. I think the USU and the treatment and the treatment outcomes, high adherence, is one of the pillars of this decline. And next to it, I think PrEP has been very instrumental because we do have quite a large number of persons on PrEP in Amsterdam. At our sexual health center alone, it's already 3,000. It's 3,000 people. I know it's nothing compared to London, but for Amsterdam, I think that's a substantial amount.
I still think that's quite a lot, bearing in mind the scale of the different cities. And how have you taken action in Amsterdam to address the stigma that comes with HIV?
Yes, stigma, very complex issue, and we're nowhere near solving it. I think the field of HIV has made giant leaps medically, but social improvements lag behind. However, some small steps have been taken, and I think it's lots of small steps that will help us progress. In our clinic, at the Public Health Service of Amsterdam, we strive to be a stigma-free clinic. So our staff is very well trained in HIV and how you can and cannot transmit it, and also in communication without judgment. And I think that's key, and I love that fact about our clinic. Then we had a small thing, but it was a nice thing, a viewing in our clinic of pictures of like an exhibition, I must say, of people living with HIV before and after their coming out as a person, being a person living with HIV. The pictures were beautiful, like made by a real artist who herself is living with HIV and who is very open about this. And I think a picture often tells more than 1,000 words.
And have you, is there, that's amongst people who go to that particular facility. What about the stigma amongst the general population? Has any work been done in Amsterdam to address the stigma of the rest of the population?
there's always a lot of debate about whether that's effective to have campaigns for the larger population. I'm not a communication expert. We have a nationwide community organization called STI AIDS and the AIDS Fund. They are quite good in doing campaigns, like campaigns for all loves, AIDS is not over. So they do quite some stigma-reducing nationwide campaigning. What is nice about Amsterdam, we have the city has a rainbow agenda. It's signed by the coalition political parties of the city council, and it has a large number of actionable outcomes for rainbow communities, to promising to tackle some of the tolerance and safety issues, some of the health issues that these communities face. There's always some attention for that, and I think that's a real nice step as well. Then we do some things on education, and also some stigma decreasing actions are very much aligned to HIV testing, because taking a test also has a stigma reducing effect in itself. So we did a health check in one of the neighborhoods where many migrants live and where there's a lot of stigma about HIV. So we offered BMI test, glucose, blood pressure, and also an HIV and a hepatitis C test. And we saw that among these groups living there, it really reduced the threshold to get a test. And we hope also a little bit of the stigma.
And how realistic is it, do you think, is the goal of achieving 0 new HIV infections by 2026? And what do you need to do to get there?
Yeah, it's a current discussion in Amsterdam too, and we also have to discuss about definitions a little bit. I think we need to aim high. HIV is still a deadly infection if not treated, and a chronic infection that cannot be cured. So what do we want? Do we 0 new HIV infections, like elimination of new infections? And I think really that's what we need to aim for. But that's not easily reached and not rapidly reached. We need a very long horizon to get there. Like a preceding stage is disease control. You can also say elimination of HIV as a public health threat. And I think that should be like an in-between aim that might sound more reachable. And it is indeed a step you have to reach before you get to 0 new infections. And we need to continue to work with it, combined with many actors, like in London, the fast-track city approach is really this combined city approach. Political leaders should be involved, and I can see that that's really the case in London. And we should all realize that it is a long-term horizon that we are aiming for. We have quite nice modeling studies that show that even if we come close to elimination of HIV as a public health threat, we cannot stop our prevention programs, and of course also not the treatment program, but that's a no-brainer. But as soon as you think, wow, there's almost no new HIV anymore, let's stop PrEP, you will see HIV infections on the rise, because we cannot, we're not one country with we're not a contained area, we're not a contained population. So we will see new transmissions if we stop our prevention programs. And I think that we should communicate and be open about, and because, otherwise, if you stop it in a few decades, you're back to where you were once. And I think continuing prevention programs is much more cost effective.
Thank you for that. And are there any lessons that you think London could learn from Amsterdam to reach its zero HIV targets by 2030 in the case of London?
I want also to be humble here because I'm impressed by London's programming. It's impressive. And London is really a leader in the approach to HIV. We've seen it with PrEP, we've seen it with emergency department testing, the fast-track city approach, for example. You may be aware that we've been that a London team came to visit us in Amsterdam. So we shared a lot of experiences, and that was extremely insightful. I think what maybe London can learn from us, but I think a lot of what I say is known by the professionals in London. But as I said, continued involvement at all levels, community, professionals, people living with HIV, politicians is needed, but because AIDS is not over yet. Political endorsement is important. Our vice mayor is very much involved. And it helps because Amsterdam has this name as a city with free sex. You can be openly gay, although there have been quite some incidents recently. Same-sex couples can get married already since 2001. The fight of AIDS started early and with a lot of effort. And I think London could have a similar image because London is doing so much in this field. So I would really suggest to London, endorse your hard work and show it to the world and be vocal about it, about tolerance, about open for migrants and people with from the rainbow community, stigma-free. HIV can be treated. Everyone is welcome, but that's a bit difficult in the current worldwide political situation. I do realize that. Programs for new migrants, including HIV testing and stigma-reducing interventions. I would like to suggest to look further and to explore how it can be expanded. Similar with programs for sex workers, we see that these populations are very mobile. I think that's a key group to look at when we get closer to the zero. In Amsterdam, we're currently reaching out to ballroom communities. I don't know if you're aware of the ballroom community.
I'm not, sorry.
No, so it's like the house of it's houses of people, often trans persons, but also people of color who look for a new family and a group where they can where they are together and often share a lot, like experiences with care, but also fun, like they do dance events and they like games, like who has the best outfits. It's really playful. There's a nice documentary on Netflix.
Well, no, it's like the ballroom culture of Paris is Burning. RuPaul started off the whole ballroom thing. I get it.
And there must be these kind of communities in London as well, and we find it a group that is potentially vulnerable, less well aware of how to access healthcare. So that could be a nice and important new angle as well. And I think both London and Amsterdam should continue to share knowledge. We're both front-runner cities. We're both good at exploring new interventions, innovations, and I hope and want to advise to London that we should continue doing that.
Thank you. So basically, we may achieve the targets if we just keep talking to each other.
Yeah, but the targets are really a bit beyond the horizon, so we do have lots of time to talk to each other.
Thank you very much indeed. Thank you, Chair.
Thank you. And do you have anything else that you wanted to add?
No, I think I have said about all that I prepared. Do you have any more questions?
Sure. No, I think that's it from the panelists today. So I'd like to thank you for your time, and to all our guests earlier for all their contributions today. So now we're going to move on to some formal business to close the meeting. Can we note the report and today's discussion? Noted. Can we also delegate authority to me as chair in consultation with party group lead members to agree outputs from the discussion? Agreed. Can we note the committee's work programme? And the date of the next official committee meeting is on the 5th of March 2025 at 10 a.m. here in the chamber at City Hall, but we have a site visit in between that next week. Sorry, 2 site visits before the official committee meeting here in the chamber. I have no other urgent business. I therefore declare this meeting to be closed.
Thank you.